Thank you. Thanks to the chair and the panel and to everybody at GIS. And thank you for joining us in this Optima session. So now that we've thought about the problem, we've heard about the variability that we all deal with on a daily basis. And Shamim has talked to us as well about what goes on in our heads, how we make decisions. I want to talk to you now about the proactive PCI framework, and I want to take you through it on a journey together, through a case. We're going to put this into action now. We're going to take away the risk. We're going to take away the variability. We don't want this to be like the Wheel of Fortune, where the patient just has to take what they get and you don't know where the wheel is going to stop. And it's this concept of uncoupling the deciding and the doing. So what does proactive PCI look like? First of all, we want to think about the goal. What does success look like to us, for the patient and procedurally? If we're going to decide on a strategy, we need to know what we're trying to achieve. Then we'll think about the challenges in the case, so that we can anticipate problems and head them off at the pass. When we know what we want to achieve and the challenges that we face, we can then decide how we set up for it, get our equipment right, think about the environment. And it's also important to think about what could go wrong. These complex cases, things do go wrong. We need to build safety nets around us so that we're ready to deal with it. So this is the playbook. This takes us through from the very first stages of making a goal and then thinking about the challenges, strategies, the setup, the bailout, and allows us to get our ideas down before we start. And you could use this. Now, I haven't given you any on the table, I'm afraid, but you've got a pen and paper, so you could actually write it down in front of you if you want as we go through together. But you could do this for every case you perform. So let's start with this case. Now, I want you to be with me every step of the way here if you can. Make the decisions yourself. I'll help you make them. Consider the angiogram. Now, I will describe it to you very quickly. We have very severe left main disease, which is probably the first thing you all spotted. And you can see some calcium. You probably also noticed that it's a left dominant system, and that's a very big circumflex. The LAD looks diseased, and it looks fairly tight down there. And there's some proximal circ disease too, but it doesn't look quite as bad. Has everybody seen the angiogram? Just nod for me if you've seen it. Okay, so just him, but that's good. Okay, well, here comes another question. So please do scan the QR code, and I want you to vote. We've got severe left main, heavy calcium, and a left dominant system. Would you vote for bypass, PCI, medical therapy? And here are the results. Well, well, well. We're all in the wrong conference. Okay, well, that's an overwhelming result. Bypass. But I can understand why you say that, because it's a big circumflex. It's a left dominant system. We've got a lot of calcium. It's left main. I mean, I would agree with you on the basis of an angiogram only, but it was a trick question because we treat patients, not anatomy, and I hadn't given you any of the important information to help you make that decision. So let me give you some of that now. Our patient's 82 years old. He has CCS2 angina, but he also has some comorbidity. He's got COPD, and an echo has shown that he's got severe LV dysfunction. His ejection fraction is 30%. And the basal to mid-inferior section is akinetic. That may not be viable. And in himself, he's pretty anxious about life. When he walks and gets chest pain, he worries about that. And that means that it limits him. He's been staying at home He can't go out and do the shopping anymore. He's scared to get on the bus. And I think you were thinking in the right way, but he was turned down for surgery, and in fact, when you speak to him, he never wanted surgery in the first place. So the decision was for PCI. Now, this is quite a complex undertaking, of course. It's a perfect case to do some proactive planning. So thinking about the angiogram and thinking about the patient, who I now feel like we all know intimately, what would be the goal? What does patient-centered success look like for him? Well, what are his objectives? What does he want? He wants to improve his angina. He wants to be able to go to the shops and get the bus and just look after himself. He doesn't want to feel anxious about his heart all the time. Importantly, he doesn't want to live till he's 120 years old. But these are his objectives. And once we've decided on what perfect looks like or what our goal is, in your wildest hopes and dreams, what you can achieve, then you can start to think about how we achieve it. So let's go through it together. What would be the challenges and then the strategies in this case? Well, we've got a severe left main and it extends into the LAD. We've seen that on the plain angiogram, and so we're going to have to treat that, of course. But we know that the circumflex is dominant and an important vessel, but some of it may not be viable. And we're aiming for a best result possible for this patient, but sometimes we don't want to take it too far. We need to get him off the table alive, and that would be more important. So we want to try and do a provisional approach if we can, but perhaps we need to know a bit more about the bifurcation before we make a final decision. And there are lots of challenges. First of all, wiring that tight LAD might be an issue. We've seen that there's severe calcium on the angiogram, and that could even be uncrossable in the mid-LAD. We'll worry about hemodynamics because he's got a poor LV, left dominant. And there are several bifurcations in there. There's the left main, there was a significant diagonal. So lots of things to think about. Well, with all that in mind, let's move on to the setup. How do we set up for success here? Well, to start with, we're going to need plenty of support and a big guide. I would say that the default in this case is going to be 7 French, and we do nearly all of our cases from the right radial. What are the targets? To be honest, I'm sure you all agree, intravascular imaging would really help us here. We know we want to treat the left main into the LAD, we've mostly decided that, but how far do we stent to? How big will the stents be? And what are we going to have to do to the calcium before we do that? We'd like to do an upfront IVUS if we can, but I'm not sure if it's going to cross. And we're going to almost certainly need some advanced calcium modification here to deal with all that calcium. But I don't know which one it's going to be yet. We'll just set up for both. You wouldn't be wrong for thinking about mechanical circulatory support here. So we're going to be prepared for that, and we might need to get femoral access. We're going to probably assess his hemodynamics first, though, on the table, and make a decision. And the environment's really important here. We're lining up a complex procedure. We need to have the team well briefed, so they're on board with you, and they're thinking about the same problems and challenges. And there's lots of equipment. We need to make sure that's in the room and ready to go. And finally, let's think about what could go wrong. A lot could go wrong here. If the lesion in the LAD is uncrossable, how will we manage that? Well, we'll rotor it. So do we have that in the room? Is the device available? Do we have gas in the tank? Has the nurse got a syringe of atropine in her top pocket? That sort of stuff. And thinking about the bifurcations, what's the chance of losing that diagonal? And do we care? Well, from the angiogram alone, it looks like it'll probably be okay. And it's not that big a vessel anyway. But we need to know a bit more, maybe. Now, we don't want to lose a dominant circumflex, of course, but it looked all right on the angiogram. So probably no special precautions there. If he goes into an ischemic spiral because we lose flow in one of those vessels, how will we manage that? Well, again, ready for femoral access, circulatory support on standby, I think. And when you're dealing with severe calcium, as we discussed in some detail yesterday, perforation is a risk and these things happen. So we'll make sure that we have a pericardicentesis kit ready and covered stents available if needed. So just from the angiogram, we've now made what are the bones of a pretty solid plan. And we've already decided quite a lot of things. Everything that I think we've decided is in green. But there's still quite a lot that we weren't too sure about. All of those things are now in yellow. We're not quite sure what we're going to have to do to the calcium. We'd like to do some intracoronary imaging, but we don't know if it'll cross. And we weren't quite sure about the bifurcations and the side branches and the risk of losing them. So how can we be more certain? It would be quite nice to understand that a bit better before we started. Of course, we want to do an IVUS, and that would be the answer to a lot of those questions. It'll tell us the length of disease to cover. Do we need to go back to the ostium of the left main or not? What we're going to do with the calcium, and then sizing of the devices, a bit more about the side branches and the bifurcations. So would you use intravascular imaging in this case? It might seem like an obvious question at this point. And if you would, which would you use? So bring up your phone and scan the QR and let's see what everybody here would do. Okay, let's see the results, please, Mike. All right, so nobody here thinks that angiography alone is sufficient. Great. And most people would prefer to use an IVUS. And we could go into why, but let's not. The trouble is, when you do intracoronary imaging, you get a lot of information. We all do it and recommend it. But again, that's a lot of thinking whilst doing, making a lot of decisions whilst using your hands and dealing with everything else in the environment. And as I say, as much as possible, we'd like to uncouple those things. You're better at thinking when you're not doing, and you're better at doing when you're not thinking. And the cath lab is, of course, a perfect storm environment, which makes putting these things together more difficult. And you might say, well, I do a lot of intracoronary imaging and have plenty of experience in these complex cases. Don't worry about that. I'll be fine. And maybe that's true, but we've seen what happens when experts use intracoronary imaging. This is data from the October trial when they did the final OCT. In about 9% of cases, there was unintended LSD, stent deformation in the left main. It's quite a lot of people in that study. And frighteningly, they didn't even know about it in 60% of cases. They only corrected 1/3 of them. And this is a bad thing, of course, because MACE was doubled 2 years in those patients. And these were experts in action, used to using OCT, expert centres. So is there a different way? What if we could be a bit more certain about these decisions before we start? And this is perhaps where cardiac CT can help us. Can we resolve some of those yellow questions? Well, here's what the CT looked like in this case. In this 3D reconstruction, you can see, well, there's a lot of calcium. And we'll come into that in a bit more detail here with these multiplanar reconstructions. If you look at the LAD panel to start with, we see mixed morphology calcium all the way down. We see it's concentric, we see it's eccentric. And if you look at the diagonal in the middle picture, again, a diffusely diseased vessel. And worryingly, there's quite a lot of calcium at the ostium. In the circumflex, again, a bit of calcium at the ostium, but maybe not quite so bad. Now, in terms of the targets and the landing zones, CT is really helpful here. This is the LAD. You can see the pattern of calcium all the way along that lesion. And by defining the proximal and the distal landing zones on the CT, we can now see that we probably need to cover about 54 millimeters. So we can start thinking about what kind of stent strategy we'll use in our head now. It's going to be 2 stents, isn't it, to cover from mid-LAD back to the ostium of the left main. And then we've got the calcium characterization. Well, we were in a bit of doubt. Is it shockwave? Is it rotor? You can see here from the axial cutouts below that the calcium's really dense and it's tight in the left main. Moving into the LAD, there's some thick eccentric calcium, and then there's more concentric stuff. So we didn't know if it was going to cross or not, if the devices would cross, but I think based on this information, we can probably decide now this is an upfront rotor case. As for the diagonal, it's pretty diseased at the ostium, and we previously thought there was a low chance of losing it, but I'm a bit more concerned about it now. The circumflex has mixed plaque at the ostium as well, and we previously thought there was a low chance of losing that, but again, a bit more concerned. And I find this really helpful from CT. It's able to tell you how much of the myocardium is supplied by each of the epicardial vessels. Of course, with a dominant circ, it's 42%. But more interestingly, look at that diagonal DG1, 14.1% of the myocardium. That's an important vessel, so we're not going to want to lose that. Now, going from our initial planning where we had some yellow bits, we've started to fill in some of the gaps. We know the target now. We're going to go from the ostium of the left main down to the mid-LAD, 54 millimeters. And the calcium's a bit clearer. This is going to be an upfront rotor case. As for the side branches, I'm a bit more concerned about the diagonal, so we need to act on that. And we know it's 14% of the myocardial mass, so we don't want to lose it. Okay, so I think we've filled in some of the gaps. We've made a lot of pre-procedural decisions. So let's see what actually happened in action. We did some hemodynamics with the right heart cath in the first place, and I won't go into detail, but it was mostly reassuring, and we decided not to use MCS up front. We took the 7 French guide as planned and some setup angiograms. And it asks you here, are there any surprises? Well, no, not really. We saw all of this coming. Because we knew it was an upfront rotor case, we went straight in with a rotor wire and took a 1.5 burr. The hemodynamics were reassuringly stable throughout the rotablation. We were worried about the diagonal, don't want to lose it, so after that we wired it and then ballooned the ostium, trying to reduce the risk of diagonal loss when we stent. As for the calcium, there was eccentric on the CT, we knew that, and we see it here when the balloon expands as well. So IVL was the device of choice to treat this, 3.5 IVL to modify the eccentric calcium. And you can see there after that, the balloon expands nicely. It's central on the wire, so that seems to have worked well. There was a lot of calcium. It was a heavy calcific burden. And so we needed another shockwave balloon more proximally. You can see the eccentric expansion here from the LAD back into the left main. Post-IVL, a 4.0 NC, tested the compliance of the lesion. And you can see now that's gone up quite well. A quick check angiogram to check on our diagonal. And we didn't inject a lot of contrast, but this proves to us here before we crack on that the diagonal is okay. Now that we've opened everything up a bit, we can get the IVUS that we wanted, but we know exactly what we're looking for. You can see fractures in the calcium opposite the diagonal. And this explains why the rotor didn't do anything to the eccentric calcium at the top of the LAD. There's negative wire bias and the rotor wouldn't have touched it. In the polygon of confluence, the circumflex looks wide open. That's quite reassuring, isn't it, when we stent across it? So we enacted the plan that we'd thought of before. Calcium's now modified, ready to stent. This is a 3.038, goes into the LAD at the landing zone that we'd seen on CT, but also confirmed with the IVUS. Diagonal was still okay, so we post-dilated and put in a second stent back to the left main ostium. Now in the angiogram afterwards, we see that the ostium of the circ is a bit pinched. We knew there was disease there, we saw it on the CT. You can see just here. Go back a page. So we ballooned the circumflex and DCB'd it. And this was the final result, confirmed with IVUS. So this plan was written before we started. I hope you can see that throughout the whole thing, because we'd thought of all the challenges, we'd strategized it ahead of time, assimilated as much information as possible. A lot of this procedure was just doing. There was some thinking, of course, but a lot less thinking because we already had made some of those decisions. And I don't know whether many of you follow American football, but these are some of the best American footballers in the league. You might think that these guys have it all sorted. They don't need to be proactive in the same way that we do because it's all just in their heads, but look at their arms. This is all of their plays. This is how they go out onto the field. Being an expert doesn't mean that it all just has to be inside your head. It doesn't mean that this just happens automatically without thinking. These guys go out with their plays all written down. They've thought of it all before. It's a sign of being elite. It's not a weakness. So, from start to finish, this was the playbook. And I hope you enjoyed going through that case with me. If you want to know more about this, we are doing it again later. We're going to have a full workshop together, an Optima session at 3 o'clock. And we'll have a smaller but interactive group and we'll work through cases together. So please do join us for that if you can. But before you do, I just want to ask you, do you think that proactive PCI can help in your practice? Please vote. Of course, there's only one correct answer. And we do have your IP addresses. Yes. Gracious at least, if not honest. Thanks very much.
Thank you.